Imagine a patient comes into your clinic, right? And they have these stark white patches on their hands.
Oh, yeah, the classic presentation.
Exactly. But then during the review of systems, they casually mention that they've been losing their hearing. And you sit there wondering, like, what do those two things even have in common? Well, the answer actually lies in the microscopic cells that give our skin its color.
It's such a great clinical curveball.
It really is.
Yeah.
And if you were gearing up for the boards, you know the drill. We'll be breaking down all major concepts covered on the exam. Today, we are pulling our insights directly from some fantastic, highly reliable StatPearls articles.
Right, but before we unpack the connection between skin depigmentation and hearing loss, we have our staggered reminder. This deep dive is for medical education only, not medical advice, and any clinical decisions should involve a qualified healthcare provider.
Absolutely. So today we are opening up the heritable disorders section of S10 Dermatology, and we're putting a massive spotlight on vitiligo.
Yes, high-yield topic. Super high yield. Our mission here is to synthesize the clinical presentation, the underlying pathophysiology, the management algorithms, and, those high-yield systemic complications.
So that by the time we finish, you'll be fully prepared for any vitiligo vignette the MCCQE throws your way.
Exactly. So let's start with the classic clinical vignette. By definition, vitiligo is an acquired pigmentary skin disorder.
Acquired being the key word there.
Right. The patient wasn't born with these specific white patches. They developed later due to the loss of functioning melanocytes in the epidermis.
And the test writers, they will frame that acquired loss using very specific descriptors in the exam stems, like you are looking for well-demarcated pearly white or depigmented macules and patches.
And just to review the basics, macules are flat lesions under 1 centimeter, right?
Yeah, exactly. And patches are the flat lesions over 1 centimeter. The morphology will usually be described as oval, round, or linear.
Okay, oval, round, linear.
But the key descriptor to highlight in your mind is the border. It is typically convex. Convex borders.
Yeah.
Got it. And these lesions, they don't just appear and stay static, do they?
No. A classic vignette descriptor is that the lesions enlarge centrifugally.
I always picture like a drop of bleach slowly spreading outward on a dark fabric.
Oh, that's a perfect analogy.
Right, because it starts as this tiny macule and just kind of creeps outward in a perfect circle to become a wide patch.
It does. And you also have to know where that bleach is most likely to drop. Initial lesions definitely have favorite locations.
Right, like the hands and stuff.
Exactly. A standard MCCQE question might describe a 24-year-old patient noticing patches on the extensor surfaces of their hands, their forearms, or their feet.
And for the face, I know test writers really love the periocular or perioral distribution.
Oh yeah, white patches circling the eyes or the mouth. Very classic.
But while that pearly white presentation is the classic baseline, StatPearls details a few clinical variants that could show up as, well, tougher distractor options.
Right, like trigochrome, marginal inflammatory, and quadrichrome vitiligo.
Yeah, those variants represent different active stages of melanocyte destruction.
Take trichrome vitiligo, for instance. It presents with 3 distinct color bands. You have the normal unaffected skin, then a transition zone of lighter brown hypopigmentation, and finally the stark white depigmented center.
So it's basically a visual representation of that progressive wave of cellular destruction creeping outward.
Exactly. It's the bleach slowly working its way out.
Which brings us to a concept every medical student highlights during derm review, the Koebner phenomenon.
Oh, absolutely vital to know.
This is the development of vitiligo at specific trauma-prone sites.
Yeah.
So a patient might present with a linear white streak exactly where they got a scratch.
Or like a depigmented ring around their waist where a tight belt rubs.
Yeah, but the trap here is causality. Students sometimes read a vignette and assume the physical trauma is actually causing the disease process. So why is the Koebner phenomenon such a high-yield detail for students to look out for during a physical exam? Is the trauma causing the disease or just triggering the location?
It's strictly triggering the location. The trauma is merely a localizing trigger.
Okay.
The patient already has the systemic predisposition or, the active autoimmune process circulating in their body. Physical trauma, even minor chronic friction, incites a localized inflammatory cascade.
So it's like a beacon.
Exactly. That baseline inflammation essentially paints a target on that specific area of skin, drawing the systemic immune system's attention right to it.
Oh, wow.
Once the immune cells arrive at the site of the scratch, they recognize the melanocytes and begin destroying them. So the trauma dictates the location, not the underlying disease.
That makes so much sense. But recognizing those spreading white patches and predicting where they show up based on friction it's just the surface level.
Yeah, we have to go deeper.
Right. To anticipate how the exam will test the etiology, we have to look microscopically at what is happening to the melanocytes.
Mm.
Vitiligo is not a simple single-gene Mendelian mutation.
No, it's definitely not.
It is a multifactorial polygenic disorder characterized by genetic heterogeneity and incomplete penetrance.
Let's unpack those terms for the exam context, because they love testing genetics.
Good idea.
Genetic heterogeneity means there isn't just one single vitiligo gene. Mutations in multiple different susceptibility loci can lead to the exact same clinical outcome.
And then incomplete penetrance means a patient might inherit the exact combination of risk alleles, but never actually develop the depigmented patches.
Exactly, unless an environmental trigger sets the whole process off.
Right. Like family and twin studies show, concordance rates in identical twins are only around, 23%?
Yeah, roughly 23%,
Right.
which firmly proves that environmental factors are absolutely mandatory for the disease to actually manifest.
So interesting. And the end result of that gene-environment interaction is the total loss of functioning melanocytes. But the exact mechanism of that destruction is divided into 5 major theories.
Yes, and the most heavily tested one is the cytotoxic or autoimmune theory.
This is the primary driver for non-segmental vitiligo, right?
Yeah. Yes. An alteration in humoral and cellular immunity basically causes the immune system to actively target, attack, and destroy melanocytes.
Okay, wait. I struggle with the textbook explanation of this autoimmune attack.
Oh, so?
Well, if the immune system is actively destroying these cells in the epidermis, wouldn't we see a massive visible inflammatory response everywhere on the skin, rather than just smooth, painless white patches?
That's a really great question. The thing is, the immune response in vitiligo is incredibly microscopic and highly targeted.
Like a sniper.
Exactly. If you take a biopsy of the center of a vitiligo patch, it looks like a ghost town. No inflammation, no melanocytes.
Just empty.
Just empty. But if you biopsy the active margins of the lesion, the expanding edge of that bleach stain, you find dense perivascular and parafollicular lymphocytic infiltrates.
So it's all happening at the borders.
Right. And we are talking specifically about CD4 plus and CD8 plus T lymphocytes. They exert specific toxicity only against the melanocytes, completely ignoring the surrounding keratinocytes.
Oh, wow. So because the collateral damage is 0, the skin remains smooth and normal in texture, just, lacking pigment.
Exactly.
Okay, so that's the autoimmune theory. The second theory is the neural hypothesis. This suggests that a neurochemical mediator is released directly from nerve endings in the skin, which acts as a toxic agent to melanocytes.
Which beautifully explains segmental vitiligo.
Right, because that often follows a specific dermatome, almost as if the nerve itself is poisoning the pigment cells along its path.
Yeah. Then the third is the oxidant-antioxidant mechanism. Melanin synthesis naturally produces reactive oxygen species as a byproduct.
And normally, cellular antioxidants like catalase clear those toxic byproducts, right?
Yes. But in vitiligo, the theory proposes a severe defect in that catalase enzyme. So hydrogen peroxide accumulates inside the cell, literally bleaching and destroying the melanocyte from the inside out.
That's wild. Okay, fourth is the intrinsic melanocyte defect theory, which argues the melanocytes simply have an inherent built-in survival defect. They fail to grow and differentiate properly and just undergo premature apoptosis.
And finally, the fifth is the convergence theory, which basically recognizes that multiple pathways, autoimmune, oxidative stress, and neural, are likely operating simultaneously.
Makes sense. Now, if an exam vignette takes you to the pathology lab to evaluate these theories, you need to know your specific stains.
Oh, definitely. Pathologists use a Fontana-Masson stain to evaluate melanin pigment.
Fontana-Masson, got it.
It stains the actual melanin black, but in a vitiligo patch, the stain shows up completely blank.
But, a blank Fontana-Masson just proves the pigment is gone. It doesn't prove the factory that makes the pigment is gone.
That's the textbook trap right there.
Right. To confirm the physical absence of the melanocytes themselves, the MCCQE will want you to select immunohistochemistry markers. The specific ones to look for are Melan A and HMB45.
Yeah. If those are negative, the melanocytes have been totally destroyed.
Okay. And because that localized destruction of melanocytes is so distinct, it dictates exactly how we evaluate the patient in the clinic. the diagnosis of vitiligo is overwhelmingly clinical.
Right, you don't need a biopsy for a classic presentation.
But you do have a vital clinical tool that test writers love to feature, which is the Woods light examination.
Yes, the Woods lamp. It emits ultraviolet, a light between 320 and 400 nanometers.
And when you shine it on vitiligo in a dark room, the depigmented areas emit this bright blue-white fluorescence.
The contrast between normal skin and the depigmented patch becomes razor sharp. It's a crucial step in a vignette to rule out other hypopigmented disorders.
Like what?
Well, like pityriasis versicolor. It's a fungal infection that might present with hypopigmented patches, but under a Woods lamp, it often fluoresces a yellowish green.
Right. And clinically, it has a fine scale. Vitiligo has no scale.
Exactly. Post-inflammatory hypopigmentation won't pop with that same stark blue-white contrast at the borders either.
Okay, so if the diagnosis is primarily clinical and confirmed with a Woods lamp, in what specific exam scenario should a student actually select skin biopsy as the next best step?
You reserve skin biopsy for atypical clinical pictures where the Woods light examination isn't enough to firmly rule out complex, potentially dangerous depigmenting disorders.
Like if the lesions aren't totally smooth.
Right. If a patient presents with hypopigmented patches that are slightly raised, scaly, or intensely itchy, you have to rule out mycosis fungoids, which is a cutaneous T-cell lymphoma.
Oh, wow. Yeah, definitely biopsy that.
Or, alternatively, if the patient has a history of travel to endemic areas and presents with hypopigmented patches that also have a loss of physical sensation.
Oh, you must biopsy to rule out leprosy.
Exactly. But for classic, smooth, asymptomatic vitiligo, a biopsy is a distractor option.
That's a great tip.
Yeah.
So once you confirm the diagnosis, the next logical step in the vignette is classification, which directly dictates the management algorithm.
The primary patterns are generalized, segmental, and localized.
Generalized is the most common, right?
Hmm.
Showing widespread, often symmetrical patches across both sides of the body.
Yes. Whereas segmental vitiligo, as we touched on with the neural theory earlier, usually involves a unilateral band or segment of skin respecting the midline.
And segmental and non-segmental vitiligo likely operate on entirely different genetic and pathogenic mechanisms.
Definitely. In a clinical vignette, segmental vitiligo typically has an earlier age of onset, progresses rapidly for a short period, and then abruptly stabilizes.
And it is notoriously resistant to conventional therapies compared to generalized vitiligo.
True. Also, to assess severity for either type, you calculate the total body surface area affected, similar to assessing a burn patient.
Okay, so choosing the right treatment based on that classification is highly variable and full of exam traps. The overarching goal of treatment is twofold. Immediately halt the immune system's progression, and then induce repigmentation.
For limited localized disease, the algorithm starts with topical therapies. Topical corticosteroids are a mainstay to suppress the localized autoimmune attack.
But you have to pay close attention to the location of the lesions in the vignette. We frequently use topical calcineurin inhibitors, like tacrolimus, specifically on the face, neck, and intertriginous areas.
And the test-taking logic there is all about side effect profiles.
Right.
Prolonged use of potent topical steroids on the thin skin of the face will cause severe skin atrophy, telangiectasias, and if used near the eyes, can induce steroid-induced glaucoma.
Yikes. So switching to a calcineurin inhibitor for facial patches avoids all those complications while still suppressing the T-cell activity.
Exactly. Vitamin D analogs are also frequently layered into these topical regimens.
Now, when topicals aren't enough, or the patient presents with widespread generalized disease, the standard of care shifts to phototherapy.
Narrowband UVB, specifically at a wavelength of 311 to 312 nanometers, is the gold standard here.
And it's usually administered 2 to 3 times a week. Let's break down the mechanism of repigmentation here because it's fascinating.
It really is.
If the melanocytes in the epidermis are already completely destroyed, how does shining light on the skin bring the color back? I always think of narrowband UVB as kind of coaxing a shy animal back out of hiding, or like activating sleeper agents.
That's a good way to look at it.
Right, because the melanocytes on the surface are dead, but deep down in the bulge region of the hair follicles, there is a reservoir of inactive melanocyte stem cells that the immune system hasn't destroyed yet.
The UVB radiation penetrates down into the follicle, wakes up those stem cells, and stimulates them to migrate upward, differentiate, and repopulate the epidermis.
That is exactly why repigmentation in vitiligo often starts as tiny pigmented dots right at the hair follicles before spreading outward to fill the patch.
Now, there is a major trap regarding phototherapy on older older question banks.
Oh, yeah. PVA.
Right. You might see an option for psoralen photochemotherapy or PUVA. You must recognize that PVA has been largely abandoned and replaced by narrowband UVB.
And we abandoned PUVA because of the severe systemic toxicity. Patients had to take an oral psoralen medication before being exposed to UVA light. It caused severe nausea, massive phototoxicity, and a significantly increased risk of squamous cell carcinoma and melanoma.
Yeah, narrowband UVB is vastly superior in safety.
But wait, if the Koebner phenomenon means physical trauma triggers depigmentation and UVB is literally radiation that can cause sunburns, aren't we risking triggering Koebner all over again by blasting the patient with a laser?
Well, it is a delicate balance. The dosing of narrowband UVB is meticulously calculated based on the patient's skin type to deliver a therapeutic dose just below the threshold of a clinical burn.
Okay, that makes sense. So since narrowband UVB is our go-to light therapy now, what short-term adverse effects do students still need to warn patients about in a clinical scenario?
You counsel them to expect intense itching, mild erythema, and severe xerosis or dry skin. If they actually blister or burn, the dose was too high, and yes, you risk extending the vitiligo.
Got it. Now, for emerging therapies, medicine is advancing rapidly. Keep an eye out for JK inhibitors. Topical ruxolitinib has been highly successful in recent trials,
It works by blocking the interferon gamma signaling pathway.
which is the exact chemical beacon the body uses to recruit those destructive CD8 plus T cells to the skin.
Exactly. Afamelanotide is another emerging systemic option to watch out for.
But when the disease is refractory, particularly in segmental vitiligo, you often have to combine modalities, right?
Yeah, using topical tacrolimus alongside systemic oral corticosteroids for a short burst to aggressively halt the active immune attack.
And if all medical therapy fails, surgical options are available.
Right.
We are talking about non-cultured epidermal suspensions, suction epidermal grafting, or punch grafting, literally taking pigmented skin from a hidden area and transplanting it into the white patches.
But there is a massive exam caveat here. Surgery is strictly reserved for patients with stable, limited, segmental, or localized disease.
Define stable.
The patient's vitiligo must have been completely inactive, meaning no new lesions and no expanding borders for a minimum of 6 to 12 months.
Wow, okay. Because if you perform a punch graft on a patient with active progressing vitiligo, the surgical trauma of the scalpel will trigger the Koebner phenomena.
Exactly. The immune system will attack the graft site, destroy the transplanted melanocytes, and the graft will fail completely while potentially creating a new vitiligo patch at the donor site.
Yikes. So managing the skin lesions requires precision, but the MCCQE routinely tests your ability to recognize the systemic implications of the disease. Vitiligo is heavily linked to other systemic autoimmune conditions.
Right. If a vignette presents a patient with newly diagnosed vitiligo, you must actively screen for thyroid abnormalities.
Hashimoto's thyroiditis and Graves' disease are the most common comorbidities. You should be looking for TSH levels or symptoms of fatigue and weight changes.
The associations also extend to pernicious anemia, Addison's disease, and type 1 diabetes.
Beyond other autoimmune diseases, there are direct complications resulting from the absence of melanocytes. Depigmented skin lacks the natural ultraviolet protection of melanin.
So these patches are highly prone to severe sunburns and carry a localized increased risk of skin cancer, requiring aggressive counseling on broad-spectrum sunscreen use.
Which brings us back to the hook we started with, the unexpected ocular and ontoric complications. A patient comes in with white patches on their skin and complains of muffled hearing or visual changes. Hearing loss from a skin condition. That sounds exactly like the kind of curveball an exam would throw. How exactly are melanocytes connected to hearing?
This completely tests your grasp of embryology.
Oh, of course, embryology.
Melanocytes don't just exist in the epidermis. During embryonic development, they migrate from the neural crest to several different areas of the body. They migrate to the uveal tract of the eye, where their destruction by the autoimmune process can cause iritis or uveitis.
And they also migrate to the instria vascularis of the inner ear's cochlea.
Yes, and in the cochlea, these specific melanocytes are entirely responsible for generating the endocochlear potential, the electrical gradient that hair cells require to translate sound waves into nerve signals.
That is so wild. When the systemic autoimmune process targets melanocytes, it doesn't respect the boundary of the skin. It attacks the cochlear melanocytes as well, leading to sensorineural hearing loss.
It's all connected. You also must screen for the profound psychosocial impact. Vitiligo carries a high risk of social stigmatization.
Yeah. The The visible nature of the lesions, particularly on the face and hands, often causes severe psychological distress, low self-esteem, and clinical depression.
And the unpredictability of the disease compounds that psychological burden. The prognosis is chronic. Patients experience intermittent cycles of pigment loss, followed by frustratingly brief periods of stabilization.
Refractory cases are exceptionally common in patients who develop segmental vitiligo before the age of 14.
This systemic and psychological complexity is exactly why StatPearls emphasizes an interprofessional care team. You cannot treat vitiligo in a silo.
Right. You need an ophthalmologist to evaluate for iritis. You need an endocrinologist if thyroid autoantibodies are present. And importantly, you need a mental health professional.
Cognitive behavioral therapy is heavily recommended alongside conventional treatments to help patients cope with the psychiatric morbidity.
Tying these systemic complications together gives us a really comprehensive framework for test day. Let's rapidly recap the highest yield takeaways for your MCCQE prep.
Sounds good.
First, identify the clinical presentation. Well-demarcated, pearly white macules and patches with convex borders that expand centrifugally, often triggered locally by the Koebner phenomenon.
Second, know the management algorithm. Narrowband UVB at 311 to 312 nanometers is the gold standard for widespread disease, entirely replacing toxic PUVA therapy.
And for localized disease on the face, prioritize calcineurin inhibitors over potent steroids to prevent skin atrophy and glaucoma.
Third, respect the systemic nature of the disease. Actively screen for thyroid abnormalities like Hashimoto's.
And be prepared for vignettes, testing the embryological connection between neural crest melanocytes, uveitis in the eye, and sensorineural hearing loss in the cochlea.
Looking at the disease through that systemic lens completely changes how you approach the patient sitting in the exam room.
It fundamentally shifts the perspective. I want to leave you with a final thought to mull over as you continue your board review. If melanocytes are actively generating electrical potentials in the inner ear for hearing and functioning in the eye for vision, and vitiligo involves their systemic autoimmune destruction, should we stop categorizing vitiligo merely as a dermatology topic and start viewing it instead as a systemic neuropigmentary syndrome?
Wow. That framing certainly demands a much more holistic approach to patient care.
It really does. Well, thank you all for joining us on this deep dive into vitiligo. Keep crushing your MCCQE prep, trust your clinical reasoning, and we will catch you on the next deep dive.